And this particular oration is basically meant for a refractive surgery. I see here a mixed population sitting here, and people on the dais who are just so experienced people of our society, and especially giving this oration with people from UKSS and AIOS really is going to make things quite lively, because young people will understand how our journey started. Older people will reflect themselves how they have gone through their society activities, where we do these teachings to give experience to younger generation. And this is a journey of almost more than 3 decades of refractive surgery of my practice. No financial disclosure from my side, and this is one slide which encompasses the entire refractive surgery journey of this 2 centuries, 20th and 21st century. You all understand, if you see the bottom line here, incision surgery, surface ablation, flap-based corneal ablation, and refractive lenticule extraction. These are 4 segments which I personally have gone through these. And there are few people who have been gone through this particular era of incisional surgeries to the cap-based procedure now. And we all know that laser vision correction till date has all those 3 components being practiced, and that indicates the predictability, the outcome being so great that nothing has changed in the last more than 40 or 50 years of laser vision correction which has been there. So let me take you through the various aspects of a refractive procedure on cornea. We can correct large number of refractive error, but we have realized now, with so many years of practice, we have to respect the cornea. What is written here is a 14 diopter myopia, 6 diopter hyperopia, and 6 diopter cylinder. We normally don't go up to that extent, because you are going to totally disorganize the corneal profile. The limit to a refractive error which can be comfortable to corneal health, not only for our morphology and strength, but optical quality wise also. That we have learned now, and we have various other ways to treat higher degree of refractive errors now by various means. But looking into a LASIK, which is one of the most predictable surgery in human body in terms of outcome wise, you can say surgery is meant for a disease process. This is actually not a disease eye, but we reshaping the cornea to correct the outcome of that pathology, which may be myopia or which may be hyperopia. Making a flap is a very innovative thing which started a long time back. So you can use microkeratome, you can use femtosecond laser device to have this flap make. As far as we are concerned in RP Center, we started with Hansetome, which was the initiation for a keratome for us. Subsequently shifted to a better one, that is a Dioptrix XP and Moria. And femtosecond we started with the FS200, now we have Visumax 500 also. These are the basic steps of surgery through microkeratome flap making. And if you see here, one of the more important thing was to make a initial mark. So that once we make a flap, lift the flap, and when reorient the flap back after the ablation, it has to really get into same shape or same coordination here, so that we don't have the disorganization of flap attachment. Keratome wise, I think it was Jose Baraka who started in 1960s, not meant for refractive procedure. He took it as a keratomyelitis procedure. But because of that, now we have a very, very high speed oscillating blades, which can make flap in such a smooth manner. The surface is absolutely non-abrated, and things can be modified in a way in terms of head size, the hinge size, the suction ring size based on ethnicity. Everything has been modified in last 3 or 4 decades to make things very, very comfortable. This is one of the latest generation MEL 90, which is being used for laser ablation, but this is a Visumax 500. The flap can be made so smoothly within a fraction of a few seconds. I'm showing Visumax here because the suction pressure generated in a Visumax is far less than the other devices, and the flap creation is so beautiful, and ablation can be done very, very fast and achieve a good results. What about the femtosecond journey? We started with, you can say, a very high energy laser ablation. Then it used to cause a collateral damage to the tissue and cause a lot of other reactions. But now you have a very low energy, increased precision, less inflammation, and better outcome in these cases also. These are the ranges of various femtosecond laser devices which we have for a practice nowadays for all of us. But best part is now we have a very, very high frequency and low pulse energy devices to get a very precise cut in these cases also. So whenever we talk about the laser vision correction or making the flap, precision and predictability are two important aspects for any procedure. And that is much better with the femtosecond laser than microkeratome. The flap orientation is significantly planar in femtosecond laser flaps, unlike in a microkeratome, which may be meniscus. And this meniscus shape can sometimes induce the higher aberration in these flaps also. So you can always see which flap is better, microkeratome or femtosecond. There have been various publications in literature comparing the initial generation microkeratome and the initial generation femtosecond devices, and they found that keratomes are better than the femtosecond devices. We also looked into this aspects of making a flap with microkeratome, superficial for a LASIK flap, deeper for a preparation of lenticule for a DSEC cases, and looked into endothelial cell viability and surface by doing the electron microscopy for cellular morphology and its viability, and using the atomic force microscopy with IIT Delhi to get this surface which can be assessed only by this technology. And we realized that microkeratome flaps are far better than the femtosecond laser if you go deeper. But if you go superficial cuts like of the LASIK flap, which is 100, 120 microns, they were equally good. So still, keratome gives you a very nice cut because they're very high speed. So if you have these two devices, cost is a major concern because a femtosecond laser has a huge cost implication for maintaining and using them. Therefore, the outcome is, I think the vision outcome is the outcome measure for these two devices. And they are equally good. There's not much a difference in a femtosecond laser or a keratome flaps in these cases. But you look into deeper part, that is the quality of vision, where you look for higher order aberrations or MTF values. Maybe femtosecond laser may be better in those regards also. But ultimate outcomes are similar. The second aspect of my journey included the various examiner laser platforms. We started with a broad beam technology to now flying spot technologies. They both have implications. We started with the Technolas 217A, then shifted to a Bosselum G100, which are much better. Then we have the examiner laser Wavelight EX500. Now we use MEL 90. So all these generations will give you a much more advantage of how you get into these areas also. That also gives you option for various way to treat your cases. Should we be doing a wavefront optimized treatment for all your cases? What about wavefront guided, detopography guided? These are the things which are included in your journey, and accordingly you manage your patients also. Complications are there in all surgical areas. But best part of refractive laser vision correction in the cornea, the complications are very, very rare, and they can be corrected also. Both femtosecond laser flap making and microkeratome flap making does have complications, but they are manageable. These are two unique complications related to femtosecond, where you can have an intracameral bubble, or sometimes you have so much of opaque bubble layer which can disrupt the laser ablation also. But I think the post-op complications which has to be looked into if we are comparing the two, especially the long-term outcome-wise epithelial ingrowth, which may be 0.2 to 2%. Dry eyes, always the major hurdle in our refractive corrections. Flap stria, if you don't instruct your patient properly, sometimes they do have this, which can be managed very effectively. And more importantly, sometimes with a minor injury also, your flap can get dislodged, and that can take away your vision correction which you got through the refractive surgery. So these flaps are very, very unstable with the minor trauma also. Even after 15, 20 years or so, flap can get dislodged. Infection is a possibility with keratomes, and dry eye, as I said, is a major concern in these cases. These inflammations are now very, very less with the neo generation advantageous systems. So this was a journey we went through, early 90s to around mid 2004 or 2004 or 5. Then we had various laser devices coming for us. So why should you think of flap to cap? Because we started from the surface ablation to flap. Now we are thinking of flap to cap again because of basic four advantages. One is a lesser adverse effect on our ocular surface, less incidence of dry eye because of that, and maybe a greater biomechanically stable cornea for a future aspects also, and lesser induction of higher order aberration. So these are a basic advantage we have. But we did not shift to this device because of these advantages, because this was a new technology. For any teaching institutions, new technology has to be taken up so that your students have an advantage of seeing that and practicing, and maybe they can innovate for future also. So this new procedure gave us an advantage in teaching and research also. And in 2016, SMILE got approval from FDA, and we procured machine in 2016 in RP Center. This is one of my patients. You can see a femtosecond LASIK and SMILE comparative, the subepithelial nerve plexus. There's a SMILE procedure. You can see within 6 months, it looks like normal subepithelial nerve endings compared to LASIK, which is still not recovered. So this will reflect indirectly, directly to your ocular surface, the visual outcome in a long run, and patient comfort also. So that advantage will always be there. This is a theoretical advantage that SMILE may give you a more biomechanically stronger cornea because you're not making the flap of 270 degrees or not cutting cornea 270 degrees. But there has been no such studies to prove that is going to be true aspects. But yes, in future we'll have some better equipment, instrumentation to judge the strength of cornea and such. Pupillary size may be little advantageous for a SMILE because you have a larger optical zone and SMILE corrections. There has been a definite learning curve for a SMILE surgery compared to the femtosecond LASIK or a keratom LASIKs. And this is a study published by Dr. Pradhan from Nepal, where he said it requires at least 80 eyes to become an experienced surgeon in SMILE. And there's a definite way to go through, and you have to understand the machine, the various aspects of picking the packs. And this surgical aspects is not very difficult if you are a corneal surgeon. So that advantage I always had being a corneal surgeon, the things were simpler, and we could do our surgery faster also. This is how fast the laser can be done. This is the lenticule being prepared. Subsequently, make the anterior cut to make a flap, and we'll have a small incision which is around 3 millimeters to dissect out or to separate the additions which may be there from anterior to posterior, and remove the lenticule out in these cases also. People do ask me if you are dissecting, there may be a rough surface both anteriorly and posterior to the lenticule, and that may be cause for poor visual outcome initially in these cases. And that was truly, people have discussed that part also. People said a SMILE patient will not have a 6/6 vision on day one, but with the understanding of machine, better titration of a laser energy, the results are absolutely as good as LASIK patient at day one also. And surgery has also become very, very effective and fast and can be done very easily also. Now, this is a study we published in a 50 patient, 100 eyes. The difficulties goes down very fast. Initially, we had around 16% of cases where we have a difficulty, and that come down to 2% within our first 50 cases. And this gave us the idea that you can always do better, modify your surgical techniques, and this was a review article we published in Clinical Ophthalmology for a difficult lenticule extraction, how to do it, what are the complications you can face if you had this, and various ways to tackle this lenticule which is attached to the cap. And this was an anti-segment OCT guided surgery where you could reinitiate the lifting of a flap and subsequently get. And we realized if you reinitiate this, you make a little bit of frill in these cases. And this is what gave us the idea to give us this nomenclature of meniscus sign for dissecting the posterior and anterior part. This is the anterior dissection, and this is the posterior dissection, and it makes a little frill if you disengage the cap or a lenticule edge in these cases also. And that makes your dissection very safe, simple, and effective outcome in these cases also. This outcome within a day one, things are absolutely clear. But you can see these two lines. This was the cap, and this is a lenticle S, and this will be visible for at least 3 to 6 months. Subsequently, it becomes very difficult to see these flaps also. You may be able to see the incision up to the very, very long time, because that gets little scarred. Suction loss is a major problem which we face, but not a problem now in a SMILE technology. You have various aspects to handle these cases. Incidence is very, very less. And you can say there are various ways to tackle suction loss with a SMILE procedure. In fact, this circle pattern, which is available only in a SMILE platform, gives you a nice way to handle your cases. This was one of my cases which had a residual refractive error where I made this cap to flap again. And this was very, very simple, and it gives you a same cut. Your initial, flap cap can be made into flap also. That D circle pattern, and this in the same uniform, you can say depth. Take it out, and you can ablate. And this, I just want to show one particular important point here. Once you lift this flap, which is a little difficult because you have sometimes can dislodge the initial cap area also. So you can see little adherent here, but see the surface after we take out this, it is as smooth as you can see in a LASIK patient also. So that is, this case was after 1 year of surgery. I could still do a good surgery in these cases also. So these are various publications, and the book I could publish in one of the first book in a SMILE in the world, and gave opportunity for people to learn faster. And we have now long-term experience of a SMILE for more than 7 years. Good outcomes in all respects, effectivity-wise, complications have really significantly decreased. If you look into complication, I think one important thing is the dry eyes. You see here, if you have a 1 month, you have a high percent of people talking about dry eyes. I say talking because sometimes you may not see the objective findings there, where patients do feel the eyes are getting dry faster. That may be because surgery, because of drops. But at 7 years, only 9% of people require a dry eye treatment, which is a significant achievement in a SMILE procedure. And you can say complication rate also very, very less. In fact, we hardly have patients for retreatment. I have had 2 patients where I had to do retreatment, post-SMILE patient in thousands of patients. And 1 patient I had epithelial growth, which was a very small, could be taken out very easily also. So SMILE does have the long-term stability. Now you have a better instrument, which is called SMILE Visumex Pro, that is 800, which is faster than of Cheetah. That means more than decrease of almost 200% time. 10 seconds you can complete the entire surgery. You have a newer platforms now. In India, you can have various aspects. You can have now 4 more platforms for refractive lenticle extractions. And these are various, specifications for those newer generation systems. So I would say lenticle extraction, people say may be difficult, but it is here to stay. If you see my results of 7 years in the RP center, it has been wonderful outcome with the SMILE surgery also. But one thing is important, we have not stopped doing PRK or LASIK, because they also give the same results. So you have 3 different platforms for us to be given to the patient care. That also gives exposure to the students and gives the opportunity for publishing more results, outcomes, so that people know through our literature also. But major challenge for a lenticle extraction is hyperopic treatment, which has to be incorporated, and retreatment. As I said, only in a SMILE you have a retreatment possibility, which is more predictable. Otherwise, you'll have to do a PRK in most cases, which doesn't have a good outcome as a secondary procedure. To summarize, our journey through flap to cap has been wonderful in terms of outcome. It's not because we took up this procedure because LASIK was inferior. Not true. Both are almost similar in terms of indications, in terms of the suitability of patients, in terms of corneal thickness. You name anything, LASIK SMILE is almost similar. But it is definitely a newer procedure, new dimension to our platforms. I'm pretty sure this is not the end of refractive procedure on cornea. We'll have a much more innovation for future also. Again, I'd like to thank all of you, especially my own society, Uttarakhand, and giving me this opportunity. Dr. Binod, thank you very much for listening to me.